So I wonder if you could first tell us why you decided to enter into the field of medicine.
Well, I wanted something that would not be just a matter of making a living. I wanted something that was involving people. And I was very interested in science. I got excited by biology, and I just, from the time I was a teenager, I really loved the idea of being a doctor. My own family doctor was somewhat of an inspiration, and I guess I remember in high school I went down to the local hospital to try to get a job when I was 16, and they said I was too young to work as an orderly, and then my father sent me down to New York City for aptitude tests to see whether I really could be a physician. They said, no, there's no way. Because I did. The reason they thought so is because I didn't have any mechanical aptitude, and that's true, I don't. I have a hard time distinguishing right from left. And anyway, I sort of put the idea aside until I got to college, and then I took a course in biology, and I loved it, and I said, I don't care what the aptitude tests show, I'm going into pre-med, and so I did in my second year of college. And I spent 2 years at Syracuse University after making the decision, 3 years altogether, and I applied after 3 years because my landlady thought it was a good idea. And I got in after 3 years, and to the State University of New York, Upstate Medical Center, and graduated in 1953. But I've always loved medicine, and I've never regretted it. I've had a kind of an atypical career in that I've never been in private practice. It's been teaching, research, and administration, and serving as a consultant in infectious diseases.
So it sounds like you've had a pretty busy career.
Oh, I have, yes. But a good career. It's been. I feel very fortunate. I've had a great life. It's not over yet.
Yeah, still plenty more to do, that's for sure. So did you finish undergrad in 3 years?
Yes, I did.
And then you went to medical school.
That's right. Yes.
And you went up to New York.
Yes, I was in Syracuse for the undergraduate at Syracuse University, and then the medical school was just taken over by the State University of New York, and ours was the first class to graduate under the state. Back in, I started in 1949. I was accepted to medical school when I was a teenager. I was just about to turn 20, but so I was kind of young for the experience, but I loved it. It was great.
Do you remember approximately how much it cost for you to attend medical school?
$800 a year.
$800 a year.
Yeah, and but I had no support from home for my college or medical school. My father had lost his business, and I had scholarships, and I worked. I always had jobs, even through medical school, and I worked constantly, and managed to get through. But I was very fortunate there too, because I had foundations that supported me. If I did everything I could to support myself, and they'd make up the difference.
Did you have to take out any loans? Or
no, I didn't. No, when I graduated, I was loan-free. In fact, I was helping my younger sister get through college, and then I went into the Air Force for 3 years, and first year in a civilian hospital in adult medicine, and then 2 years in Japan. And that actually year in the civilian hospital, everybody else got $15 a month, and actually, yes, it was $15 a month in room and board, but I had a commission in the Air Force, so I was the richest intern in the place, and I bought a car for the first time. After all those years of relative poverty, I was really in good shape. And then the experience in Japan was very good, and got married, and my wife came over 4 months later, and our first child was born in Japan, and we came back here to Rochester, New York, and had my residency there in pediatrics. I decided to go into pediatrics because the surgeons and the internists didn't really have the interest in doing pediatrics, and they wanted a volunteer. So I volunteered to do pediatrics. I had enjoyed it in medical school, and so when I got out of the service, I decided I really wanted to go into pediatrics. And I applied to different places, and Rochester was good for us for family reasons, and my wife was a musician who had been in graduate school at Eastman. And so we went to Rochester and spent 2 years there, and then to Harvard for 2 years, as a fellow in infectious disease, and then back to Rochester for 15 years on the faculty. Then I came here in 1975 to start the Department of Pediatrics, and that was exciting. I think I'm the only pediatrician, maybe the only physician who's had an office in 4 hospitals in Worcester. As soon as I got to Worcester in 1975, St. Vincent Hospital asked me to be chief of pediatrics there as well as here. The hospital wasn't open here. And I never expected that, but that was where the residency program was. That was where the patients were. We had nothing here. We had to train our students over there. So although I never even considered it, I never thought of it, I was pleased to do it, and I did that for 5 years and sort of went back and forth between the 2 places as we were getting started here. And then I stayed here for 17, I was chairman for 10 years, and then I was the dean of the medical school for 5 years and provost of the medical center. And then I resigned from the deanship and after 5 years, and then went to Memorial Hospital and was chairman of pediatrics there. My office was at Hahnemann Hospital and then at Memorial Hospital, and they consolidated all the pediatrics at Memorial that they had at the Medical Center of Central Massachusetts. So I have managed to have 4 offices in 4 different hospitals. I was thinking about that the other day. It's kind of unusual, but it makes you much more ecumenical because you know the staff in these different places, and there are good people in all the hospitals. And you know, Worcester has a tradition of a lot of rivalry among the medical schools and the medical centers. But having worked and gotten to know the people in different places, I always felt that was not a very good way to look at things medically in Worcester, and we should be much more working together. And then many times it was very unfortunate. The competition got out of hand, I think, but now that seems to be much less so. And when I came to Worcester in 1975, you could admit a child to 7 different places for hospitalization, and now there's only 1, and that's here. And that's a good thing because there's a concentration of specialists and people who are focused entirely on children. And I'm sure it has its downside, but it's, I think, the upside. Nowadays, a child doesn't get admitted to the hospital unless they're very sick. And sometimes these are very often life and death situations. This is the kind of practice that I had. It was infectious disease, children with meningitis who came into the hospital. They were hospitalized children with severe infectious disease problems. So, you know, if you could call it a practice, I guess it is. It's a consulting practice. It was, in that sense, different from what most people in pediatrics experience.
So did you do an infectious disease fellowship after you did your pediatrics?
Yes, I did. Yes, I did that at Children's Hospital in Boston and Harvard Medical School. I worked with a wonderful person, a Nobel laureate, Dr. Thomas Weller, who won the Nobel Prize for isolating polio virus, with Dr. Enders and Dr. Robbins, and in 1954, and I went to work with him in 1958, and from 1958 to 1960 until I went back to Rochester, and my lab was in Harvard Medical School. My patients were in Children's Hospital, and I first got interested in virology when I was an intern. The big disease of my internship was polio. And polio, it's hard to imagine now, but people were terrified of polio. You know, the president had had it, President Roosevelt had had it. But children would die of bulbar polio, but more importantly, they were crippled. So many were crippled for it at an early time in their life, and it was a very, very disabling. I remember as a child, my mother wouldn't let me go to the movies or the beach, because of polio epidemics. And the worst polio epidemic I ever experienced was as an intern in Cincinnati. And people were lined up around the block waiting to get into the emergency room to see if they had polio. And I remember being on duty as an intern alone in a hospital that was devoted just to taking care of polio patients. And they were all these, they used to call them iron lungs, these ventilators that worked mechanically. And one night in the middle of the night, the ventilator went off on this man who was about 32 years old, an engineer. I'll never forget it. And I had 1 student nurse and 1 inexperienced intern trying to get him out of one ventilator and into another. And it was just a horrendous experience, and he eventually died, but he didn't die that night anyway. He died for another reason later on, but it was the disease that kind of focused a lot of my attention on infectious disease, and I was very excited about it. I tend to get very passionate about things, and I went to work with Dr. Weller because he was sort of at the forefront of growing viruses in tissue culture at the time, and he was also a pediatrician by training, and he was relatively young. He was only 38 years old when he won the Nobel Prize. And he was a wonderful person. We only took one fellow a year, and I worked with him. So I had a lot of supervision and a lot of one-on-one with one of the great figures of the 20th century in medicine. And
what sort of research did you do?
I worked on cytomegalovirus. He had just isolated cytomegalovirus, and I worked for about 6 months with different viruses. Then I decided I really wanted to work on cytomegalovirus. At that time, cytomegalovirus was really esoteric. It was considered the rarest of the rare. A lot of physicians had never even heard of it. It used to be called cytomegalic inclusion disease, a rare disease in children, a congenital infection. And of course, now it's recognized as a very common disease, and in patients who have transplants and grafts, and patients who are immunosuppressed. It is the most common congenital infection, but these other things were not known at that time. And I guess my main interest was to find out how important it was, and so I started doing surveys of children, newborns, and children and older children, and I found that it was very common. That was the first indication that it was not just a rarity, and that 1 in 100 children were born excreting this virus in the urine at the time of birth. And of that group, a small percentage, 20% or so, had serious effects from it: deafness and retardation, cerebral palsy, blindness, large liver and spleen, jaundice, things of that nature. So that was a kind of an exciting thing, and you know, the research years it was about a 17-year period, something that range from 1958 until I came here in 1975. That was the main thing I did together with the teaching and the consulting. I took a sabbatical from the University of Rochester in 1971 to go to a hospital for sick children in London, and I started working on a book there on congenital viral infections, and with the man who was head of infectious disease there, Dr. Alistair Dudgeon. And then I came back to the United States, and I thought I'd try running a department of pediatrics in one of our affiliated hospitals in Rochester, and I was chief of pediatrics there for 3 years. And then I started to look around at different places to go. I got, people were, I got inquiries about chairmanships of different departments, and so I went to about, I guess a half a dozen or more, and considered about a dozen different places, and then I heard about this place. It was just getting started, and I came and I met Dr. Suter, and I think I was the last chairman that he hired. It was in December of 1974, and I was impressed with him. I was impressed with Brownie Wheeler and a lot of the faculty that had already been signed on. And I thought, well, this place, it may not look like much now, but it is going to be a very good medical school in the long run. But I knew it was going to be a very difficult thing. It was an empty building, and it was in a sea of mud. There was no hospital. You had to be a certain kind of person to want to get into this. There was nothing. No secretary, no wastebasket, no nothing. Anyway, but the building itself was very nice. It still is. I still like the building. Some people think less of it than I do, but I've always thought it was a drawing card. And I also thought that a medical school in the center of New England has a lot better chance to recruit very good people than a medical school in Des Moines, Iowa, or someplace more removed from from where people are trained and where many physicians get their early training. So that turned out to be true. I think in starting the Department of Pediatrics, Dr. John Duggan, a practitioner in town, had been the interim chairman. And for I think from 1972 until 1975, 3 years. And he's retired now, but he did a very good job starting things, the curriculum for the medical students. And
so were you initially just involved in setting up the Department of Pediatrics?
yes.
And then later on you got involved with the teaching aspect as well, right?
Oh yes, oh yes.
And how did you get involved? What did you do as far as teaching within the medical school?
Oh, well, lectures and making rounds, conferences. We had both residents and medical students. And this was a major activity. When I came, I had a laboratory, but I didn't have any time to continue my research. My priorities had to be developing a strong teaching program for medical students and residents, so we could attract. No resident is going to apply to a program that doesn't even have a hospital, and you had to build up the patient base, and there were relationships with the people in the community and in central Massachusetts were very important. And in accomplishing, in doing these things, you had to think about how people in the community perceived you. We were considered a very threatening influence around us because, this big building, and I think some people would say, well, we have about 10 years before we'll be all finished in practice because they're going to take over everything. And of course, that wasn't the primary mission here. Was teaching and research, and the clinical care really was the basis for the teaching in the clinical years. And but nevertheless, I think gradually over time this abated somewhat, and I think is really not a big problem now, not any more than any other place. Like the University of Rochester is Strong Memorial Hospital is the dominant medical center in the community, and I think it works very well with the other hospitals. And I think the situation here is much better than it used to be. It used to bother me that there was this friction and competition and rivalry. I thought it was unseemly for physicians to take that point of view. We're all in this business to help patients and to teach younger people, and I've always rebelled against the idea that we're like General Motors and Chrysler and competing with one another. Anyway.
So you mentioned that when you first came here, there was something like 7 or 8 hospitals in the area.
That's right.
And now we're down to about 3. 3? Yeah. Well, 2 really.
Yes.
One system and then,
yes.
What used to be St. B's. Do you think that's happened because of the medical school coming to the area, or do you think it's other factors that have...
Well, I think there are a lot of factors that are happening at the same time. The increased pressures on hospitals from a fiscal point of view has made it very difficult to maintain a pediatric service. They're expensive, they don't make any money, and they frequently are, in order to do it right, you really have to have a lot of people who are geared toward children. And so I think as time went on and there became more and more confidence in the medical school and in the UMass hospital, the practitioners in town would send patients here. And then St. Vincent decided to get out of the teaching business with residents, and so we withdrew our residency program. By that time it had become the UMass residency program, and just had the residents here. In some ways, I think many people felt that was a mistake on their part. From my point of view as director of the residency program and chairman of the department, it made it easier for me to recruit 6 or 7 residents than 13. I needed more residents to staff more places because we were at Memorial Hospital in the newborn intensive care unit. We were at St. Vincent, which had a fairly large pediatric service, required a large number of people, and then this place. And So, and it turned out that way. As we went more for smaller numbers, the quality of the residency went up, and now we have 150 to 200 applicants for every position. It's a very selective residency program with, I think there's 7 in each year now, 7 or 8.
So just take a step back. When you initially came to start up the pediatric department, how many people did you put on staff when you first began?
Well, I was here alone for about 3-4 months, and then I recruited the first person, a practitioner, one of the best practitioners in Rochester, Dr. Sumter, and he came as outpatient director. And then Mary McMurray, who just retired, who was at St. Vincent, I recruited her the following fall. And then I began to get people from Boston and the subspecialists, and so the first year I may have had 3 or 4, and the second year maybe 6 or 7. It was gradually over a period of 10 years that the 10 years that I was doing this, recruiting people, that it gradually built up to something like 35, I think, when I left to go to the dean's office. But it was kind of interesting to do it. I had a lot of friends who helped me in Boston at Children's, and I had a very good network around the country to find out who the good people were and who was interested in moving, and who might be the kind of person who could come to a new school and deal with the stresses and uncertainties of a new medical school. And I'm very proud of the department. I think when I stepped down, I recruited Dr. Charney when I was dean, who was someone I had worked with at Rochester, who was in Baltimore, came from Baltimore, and he was the second chair for 10 years, and I was chairman of the search committee that brought Dr. Felice, who was the third chair, who started a few years ago, and they have been excellent people.
What are some of the challenges you faced when you initially began recruiting people to a seemingly empty hospital?
Well, you know, there were really so many crises. You know, they kept saying that the state medical school is going to be closed because of financial problems, and you know, some people were very worried about coming to a place like this. It wasn't established. It didn't have a track record. This is in the early years, although now years later it has an incredible track record. But in the early days, nobody really knew for sure. We had a building, and that was about it. And we began to attract better and better medical students, and it became a tougher place to get into than most of the medical schools in New England, with very few exceptions. And but I think the uncertainty and the lack of a financial base and the patient population was pretty small. We did have advantages, though, in the research. This was a good place for a researcher to come. Because of arrangements we had, we supported them with laboratory space and financially, and I think that worked out pretty well. So we wanted to build a department that really was, you know, a department that was gaining new information, was teaching, and was showing excellent patient care to our residents and our students. And it was the model that I was used to in Rochester, which is one of the best pediatric departments in the country. And I think it's worked pretty well here, and I'm very proud of the department.
Are there a lot of similarities between the pediatric department that was here and the pediatric department in Rochester? Did you take a lot of your experiences?
Yes, I really used them as a model. And I think the chairman of the department, who was a very important influence on me personally as a resident, was a wonderful man. When I was a faculty member later, I had an office right across from his, and he was wonderful with the patients. He was great with the residents. He was a very sort of a grandfatherly kind of man who had a sort of a down-to-earth, wonderful sense of humor, and he was a very sharp clinician. He was always stimulating people to do things in the laboratory. He had come from Washington University in St. Louis, and his name was Bradford, William Bradford, and he was an inspiring person. He encouraged young people to go to their highest level, and And there are others on the faculty there that, and I wanted to do that for our residents too. And we now have a pediatric society that is geared toward supporting residents so that they can go to meetings, national meetings, and so some of the things that they can have while they're in training here. And I think that's very important.
Then after that, you became dean of the medical school?
Yes, John Howe, who went to become president of the medical center at San Antonio, left, and he was the academic dean and vice chancellor. And when he left, I was appointed. And then I wasn't sure I wanted to be a candidate for the permanent position, but I did eventually become a candidate. And then they had a national search, and then I was appointed, and I stayed in that office for a total of 5 years, 3 of them as the permanent dean. And then a new chancellor came in, and we were really not on the same wavelength philosophically, and so I thought it better to resign and encouraged Dr. Lazar to take the job.
So we took it right after you left?
Yes, I recruited Dr. Lazar. In fact, if I can take a little credit here, I recruited him as the chairman of, this is one of my sidelines, recruitment.
Yesterday?
Pardon?
This is what you were saying?
That's right, yes. Yes, I know I recruited him into the chairmanship of psychiatry, but I also observed that this guy had all the makings of a very good dean. You know, being a dean is a very tricky thing. You have 18 prima donnas in 18 different departments, chairs of the department who are used to getting what they want, and they're very good at getting what they want, and so you have to juggle them all. And I thought he would be, being a psychiatrist would be very helpful, and I think it proved to be very helpful. I also thought he had vision, and he had courage, and he had wisdom, and he had the common touch. You know, he could talk to people. You know, he grew up in Bayonne, New Jersey. He came from a working class family, a very modest background, and he likens the politicians to people that he played stickball with on the streets of Bayonne. And he got into psychiatry. He said his mother was practicing psychiatry without a license in the neighborhood. All the people in the neighborhood would come to her for counseling, and you know, he's a very kind of down-to-earth kind of guy, but he's near genius level when it comes to dealing with people and interactions of understanding what people need and where they're coming from and what it takes to make a negotiation and affiliation. He's really been very good at bringing people together. You know, the Worcester Foundation and the UMass Memorial merger. I never thought that was possible. When I left here to go to Memorial, a few months after I left, I was in my office at Hahnemann in the first year, and Dr. Levine said, "What do you think about a UMass Memorial?" This was in 1994, long before. I said, "Well, it had enormous problems." And then by the time I left, 6 years later, the merger had been accomplished. It still has a lot of problems, but the problems are mainly the problems of the national reimbursement for medical care and Medicaid and Medicare. I think that every medical center is facing, and there are other maybe local problems as well, but those things will gradually work themselves out.
So what sort of changes occurred within the medical school while you were dean?
Oh, let's see. Well, we had 3 chancellors. Well, we had Dr. Tranquata, who had been here for 7 years, who made, he was also chancellor and dean, and when I became dean, they separated off the deanship from the chancellor's position, and then later they put it back together again, because frequently the dean would be going one direction, the chancellor would be going in another, and it was kind of a setup for conflict. Dr. Dahlin was then the interim, and then I was the interim for a while, and then a new chancellor came, and I think it was a period that was a difficult period, because we had increasing reduction in our money from the state. We went from something like 34 million, I think it was, to about 20 million. It was about a 33% reduction of state funding, which put a squeeze, even though a lot of our revenue came from group practice and from research. we still depended on that core funding from the state, and that put a lot of pressure on us, and the relationship with the state legislature became more and more important. And that was a difficult time for the medical school. As far as the students, during those years we started to show improvement in our research side. I know the basic sciences were strong. There was an increased amount of clinical activity in getting research grants, clinical research. And I think that that took off during those years. They were all sort of set in place. Dr. Tranquata is the one who started the biotech park across the way during those years. And we started making some efforts in the community for fundraising, which has really taken off since then, since Dr. Lazar has been the chancellor. The residency programs, the whole institution was becoming stronger. I think the reputation of the faculty was getting stronger, and residents were being attracted from around the country. And Department of Medicine was, and Department of Surgery. If those two departments are not working, then there's a big problem in a medical school. And I think they were strong, and the pediatrics was doing well. So I think in general, we were attracting good medical students and increasingly good residents. The residents were very important because they had such a profound effect on the medical students. You know, when they get to the clinical years, they learn more from the residents than they do from the faculty. And that's why a strong residency program is absolutely key to a medical school.
Did you enjoy your years as dean?
Oh, very much so, yes. I enjoyed everything about it. You know, it is an opportunity. You spend a lot of time recruiting chairs. The ones that I remember, the chair of OBGYN, and I guess they call it molecular, it used to be anatomy, and now they call it molecular biology. I'm sort of blocking on the name. Well, it'll come to me later, but anyway, there were a number of people, I think 5 or 6 chairs that were appointed during that period of time, and I enjoyed doing that. It was,
seems like it'd be very challenging.
Well, it is. I think trying to sell the institution, it was still an institution that was young, and it started somewhere around 1970, and that would have been in the second decade of the medical school, from 1984 to 1989. I think that's the second decade. But it was an exciting time, and I did enjoy it. But you know, I think the problem was that you really have to have the dean and the chancellor working together, and that was not the case. And I didn't feel that the chancellor was a good choice. And
I'm going to ask a naive question and ask what were the difference in responsibilities between what a dean would do and what a chancellor would do?
The dean is the chief academic officer for the medical school, and the provost involves the other schools as well, nursing and the biomedical sciences. But the chancellor is the overall CEO of the academic health center. He deals with the outside world, the political world, the state agencies. He is the spokesperson for the entire institution, and his philosophy and his persona, his manner of doing things either advances or retards the development of the medical center.
Stagnates it.
Yes.
So since you left your appointment as dean, what have you been doing?
Well, I've been doing college health. That's been my main clinical activity. I've been I took a year sabbatical after I resigned, and I learned how to do college health. I had been in administration so long, and I'd never been a generalist. And I thought this was a nice age group. You know, I couldn't do too much damage, and I was interested in them. And it was largely infectious disease, which was my interest. And so I took a year and went to UMass Amherst, and they have a big operation there. Did you go there?
Yeah.
Oh, great place. They were very nice to me. I had all these experienced doctors. I was like a resident, you know, and I could say, what do you do for this? What do you do for that? And so I became a real doctor after all these years. Instead of a bogus, you know, and it was fun. I liked it, and then I came back and I worked at Holy Cross, and I worked at Clark and WPI, and then gradually I consolidated all my efforts at WPI because I liked the way they were set up. It was a much more efficient operation. I liked the patient population, and I could do my other things. I went to Memorial Hospital as chief of pediatrics, and I could do that and this at the same time. And Dr. Levine asked me to come over there. It never occurred to me, actually, to even apply. But I went over there for a meeting of one sort, and I sat next to one of the doctors, and he said, have you ever considered coming over as chief of pediatrics? And I had stepped down from the deanship for 2 or 3 years by this time, and was devoting most of my time to college health. And I said, I hadn't thought about it, but I'd be interested in talking about it. And so I was appointed shortly thereafter. And so after 17 and a half years here, I went there for six years. And that was a wonderful experience. I liked working at Memorial. I got to know all of the cast of characters. I knew a lot of them before, but it was bringing together the different elements. They had an inpatient operation at Hahnemann Hospital that was separate from the NICU and the newborn and the normal newborn service at Memorial. Then there were other fragments here and there, and this sort of brought it all together at Memorial. And we opened up an urgent care for when doctors closed their office, the patients could come there. And we had a telephone lines that developed, it was one of the first in central Massachusetts, where patients could call in and could be advised as to whether or not they should bring the child in, whether they should wait till the morning, take 2 aspirin, call me in the morning, or whatever they should do. And that was an innovation that we developed there. And so they were good years, and I think it sort of rounded out my Worcester experience, having been at St. Vincent for 5 years.
Were there any feelings at all from people at UMass that you were going over to Memorial? Because at that time they weren't merged together, right?
No, I don't think so. Well, if there were hard feelings, they were not expressed. I think there was some anxiety that I was going to compete with UMass, and if they knew me at all, you know, I put my heart and soul into the development of UMass, and I would never have done anything. That was the one concern I had about it, that I might have been put in an awkward position, but I never was. And I almost didn't go over there for that reason, because I had a concern that they might have the crazy idea that they could compete with this institution. And you know, realistically, there's just so much that's required for a tertiary care pediatric center that it would be economically all wrong. It just, aside from, in every way, it would have been wrong. And so, but it never came up. So I was even the people that I used to sort of disagree with, who were over there before, who were then in my department, worked very well once I got over there.
And now the merger didn't take place until after you left?
It was in the last few years. Let's see, I left in 99. I left Memorial in 99. I went to Memorial in 93 for 6 years. And the merger took place around 97, 98. And that's when I came back here. Dr. Lazar asked me to come back here as chairman in both places during this transitional period. And Dr. Charney stepped down, and I did that for 14 months until Dr. Felice came. And that was interesting to come back to the job I'd had 14 years earlier. And the meetings, oh my gosh, I complained about the meetings. There were so many meetings that the chair had to go to between here and Memorial, and Dr. Lazar said, don't worry about all those meetings, just concentrate on getting a good chair. And so we did that. And,
how'd the dynamics change during the merger period?
oh, well, I don't think during the period I was here that they had changed that much. I think the changes have occurred since then. Now, or in the 2001, I think that it's harder. I think the administration is under enormous financial pressure. And there's no, I think what has happened, and that makes it's very difficult to keep up faculty morale. A lot of people who go into academic work do not envision that they're going to be working the way a person would be working in private practice. And they are really being expected to earn their keep by seeing patients. And there's only one way you can do that, and that's to put everything else on the back burner. And the teaching and the research aspect of academic life is what suffers, I think. And there is something disheartening about that. And I don't know that it's anybody's fault. I think it's the fault, the fact that Medicare only reimburses something like 70-some% of what it costs us to take care of those patients. And this is why we run deficits every year. And that if the state doesn't help us, that we'll be faced with yet another fiscal crisis that we had in 91, 92 when they were threatening to cut off all support from the medical school.
It seems like that can also be a threat to medical education.
Oh, yes, it is. It's a big threat.
Is there anything that you can envision that might help the problem?
Yes, I think a bigger allocation of resources from the state, particularly when they have a $58 million surplus. Maybe more than, no, it's more than that. No, it's considerably more than that. They were talking about $100 million to be given to hospitals. I think it's maybe $580 million. Something. It's a fairly large amount of money. I think it's something like closer to $600 million. I was reading in the paper yesterday.
Me too. I can't believe that either. So through all this, I know you've also been a pretty avid artist.
Oh, yes, yes. When I was dean, my wife says, you do nothing but work. You should do something, go down and take art lessons at the medical school, and I did. And I'd always been interested in art. I used to do one picture every 10 years or so, and when I was a resident at Rochester, every year they had a show for people who worked there, and I put a couple of pictures in. And anyway, I always loved it, but I never had time to do it. And I have a great wife, by the way. We've been married 47 years, and she has very good ideas. She said, go down and take art lessons. And so I did, and I really loved it. And I just really caught on to this one particular teacher. And I worked in pastel landscapes, and I'm now represented by a gallery in Westboro, and I've had 6 one-man shows, and I have my pictures all over the place. They're about people, about 60 or 70 of them are in people's homes and some in institutions, and it's been very rewarding. It's a passion, you know. Like cytomegalovirus was a passion at one point. Now the art is a very big thing in my life. As you get older and your professional life diminishes, and I think it has to diminish in a way because you have a lot to remember as a physician, and that will be the point where I stop seeing patients, when I feel that I can't do a good job. And I think my wife will tell me when I can't do a good job. She always gives me good advice. But I'd like to continue as long as I can. I'm 70, I'll be 73 this year, and I used to think that was ancient, but I don't feel ancient. And I'd like to work as long as I could, at least so I have a time for a more balanced life. It's a great time in your life, by the way. You've got a lot to look forward to. Old age is wonderful.
As long as you're healthy.
Yeah, that's right. That's the big catch. And I'm having a surgery on Monday, the first time I've ever had surgery, but it's for urethral obstruction, but something that happens to many men.
Good luck.
Thanks.
Has medicine at all worked its way into your artwork, or is it mostly just landscape?
Landscape and people. I've been doing some portrait work recently and figures, and medicine has not been a subject of my artwork, no. It's pretty much separate.
So you talked about your family a bit. I was wondering if it was difficult at all throughout your career balancing your personal life with your professional life.
Well, I didn't think so. I think I always worked very hard, and my family were very accustomed to my working 12-hour days. But I would come always home for dinner at night. In a way, I had an advantage that many people did not have, who were more closely tied to a large volume of patients in a private practice setting. I had a little more control over my hours. I would be called at night, but it was usually for a child in the hospital with meningitis, but it wasn't that often. So I would be able to be at home at dinner with my family. I had five children in different, we had 3 in rapid succession and then a 9-year interval. We had number 4 and 5. But that was a very important thing to be able to do that. And then I would work at home in the evening. I would do, I was writing papers or doing administrative work and preparing lectures, and I would always work 2 or 3 hours in the evening. And then on weekends, I would too. And I did that for many years, and it sort of became a routine, but I was always had enough time with the family. And family was very important to me. And I have a great family. Our oldest son is 45, our youngest daughter is 32, and they haven't turned on us yet. they're a good group. And
what sort of advice would you have for a young physician or a young medical student just entering into the field of medicine?
Don't work so hard that you neglect your family, because that's the important, really base, I think, for most people. You've got to have a sort of a solid rock. When the going gets rough, you've got to have a solid rock that you can hang your hat on. And I think nurturing a strong family is very important. And I think we're all, in medicine, we're all hard-working people. We're ambitious in a good sense, I think, because we see that we can do a lot of good things. I think it's important for young people to remember that no matter what happens to the politics or the economics of medicine, that medicine will always have an appeal because of the doctor-patient relationship. As long as you sit down and talk to a patient and you're doing something for that patient, there will be satisfaction that will come back to you. If one expects a lot of reward financially, I think you may be disappointed. I don't know that medicine is going to be quite as lucrative in the future as it was for some people in the past. It was never lucrative for pediatricians, by the way. But every decision I made along the way was really never based on money. And I have no regrets about that. And I think your reputation for integrity and honesty is absolutely essential. And I think you should never do anything to put that into question.
Good advice. Do you have any fond memories that you look back on?
Well, I guess as a young man, I think my first presentations at national meetings and being asked questions, and they used to have the meetings in Atlantic City, the pediatric societies, and by these people who were so prominent, and that was kind of a thrill, and that was something that was repeated over the years. And but the first time you do anything like that, it's a very competitive sort of thing to get on the program for a plenary session, and so the work that you're doing is being recognized as important, and then you present it yourself, and then you respond to questions, and when there are thousands of people in the audience, it's, for a young person, it's kind of a heady experience. So I think that was a memorable occasion, and then getting the support from NIH was exciting. I was fortunate. I had a Career Research Development Award, which paid my salary for 10 years when I was at Rochester. that was what made it possible to take the last year in London as a sabbatical at the Hospital for Sick Children. That was a very nice experience too, living in London.
Maybe you can go into that a little bit so we didn't talk about that.
Pardon?
What were your responsibilities there? Did you do infectious disease?
One of the nice things is I didn't have too many responsibilities. I did some research, and started to write this book, and I lived in, we had 5 children by then, and the logistics of getting them all into schools, I lived about 2 hours away from the hospital in Surrey, but it was a great experience. It took me about 2 hours to get to work in the morning, going on a train and into London, and my wife would always come in on Fridays, and we'd do the art museums and the art galleries, and I must say it was a nice balance of work and play after many years of really gunning it, and we had a great experience.
I'm not sure how much time we have left. Is there anything that we haven't talked about that you'd like to talk about? Last few minutes, so we don't keep running out of questions. About 10 more minutes.
Well, I'm generally optimistic about the medical center. I know we're going through a bad patch right now, and we've been through many bad patches before. The history of the medical center is a history of crisis, one after another. We've had our Cuban Missile crises many times, and the bigness is a problem. I think because we're so much bigger, the most difficult thing for the chancellor and the CEO of the hospitals is to maintain high morale among the students, the workforce, thousands of people who are associated with this institution. It becomes even more difficult with the merger. But I think this will happen, and it's going to be extremely important what happens with the leadership, the kind of person. I don't think there's a CEO in the country who's run an academic health center who has a record comparable to Dr. Lazar's. And when you look back at things that he's done in the 10 years, it's just amazing. You know, the affiliations, the associations, the building that's going up for the research activity. I don't think there's another CEO who could match that. But he's coming now to the 10th year. He's in his mid-60s, and who follows him is going to be very important for this medical center and medical school. And equally important is who is in charge of the health center, the clinical component, and that these two elements work together. They have to be such a rare combination of business person, leader of physicians, a person who can interact with the community and the many outside aspects of the community, the political structure. And it's very difficult to find these people, and I think it's easy to make a mistake. We've made our mistakes here before. We can't afford to make any others. And I just hope that, I'm confident in general. I'm an optimist. I've always been an optimist. It's just my nature, and I'm sure that we are going to do very well. We've already established ourselves as one of the most successful of the young medical schools established since the 1960s. In terms of attracting federal funding, in terms of recognition nationally for primary care education. So I think in spite of the current difficulties and the low morale that I perceive, this too shall pass, and we'll muddle through, and I hope that people can sort of keep their eye on the big picture and not, when you think about Worcester, Massachusetts, and compare it with North Korea or hospitals in Russia and the working conditions and the deprivation globally, we still have a very good situation here in the United States and in Worcester. And so I think you have to keep a perspective about the hard times and keep your eye on the big picture.
Another question about Worcester. Since you worked as a chair at many different hospitals in Worcester over quite a number of years, did you see any changes in the needs of the pediatric population within Worcester?
Yes, I think, I don't know so much about the needs. The needs are, always been there. The private practitioners have done a very good job here in Worcester, and I think that continues to this day in taking care of patients, and only a very small percentage of these patients really ended up in the medical center, as I mentioned before. They came to the hospital, to a tertiary care hospital, or required hospitalization. In the early days, you'd have one pediatrician who might have 7, 8, 10 people in the children in the hospital at any one time. Now, that is totally different. Very few children get admitted to the hospital. Most of the time, most pediatricians don't have anybody in the hospital. And these people are managed, these patients are managed on the outside. And the treatment of asthma, for instance, is a very good example. There have been so many advances in the management of children with asthma. One of the most common reasons for hospitalization and for ER visits is now being managed very successfully by people like Dr. Zwerdling, who sort of led the way in this area in the management of asthma on an outpatient basis, reducing costs and making it better for families.
What sort of large changes have you seen as far as technology and drugs within medicine over
gee, well this is
the big ones?
Yeah, those are big ones. And I think one of the wonderful things about the field that I'm most interested in, of course, is infectious disease, and it happens that infectious disease has been one of the most dramatic, not only the antibiotics, which were streptomycin came into being when I was a medical student. Penicillin had been around since World War II, and sulfa. But then the proliferation of other antibiotics. But I think the thing that I was closest to as a young clinical investigator was the development of vaccines. And having worked with a physician who isolated poliovirus, and he made it possible for Dr. Salk and Dr. Sabin to develop their vaccines, because until he did the work that he did, it wasn't possible to develop a vaccine because there was no virus in a tissue culture tube that you could work with. And so that was the model for measles vaccine, chickenpox vaccine, the Haemophilus influenza vaccine for meningitis, which has very greatly changed the number of admissions to the hospital for meningitis. It's markedly reduced epiglottitis in children, which was one of the biggest nightmares a pediatrician could have, the sudden onset of constriction of the airway from swelling of the epiglottis. And so many things now are better. There are still the problems of mental health in children and young adults and people in general. There have been a lot of advances in that area, in psychopharmacology. Some people say some abuses too, but I think most people who know about this field think that there is an under-treatment of depression in young people and children, and I would tend to agree with that. There's no substitute for the solid family in the mental health development of children. But you asked about the needs changing. I think the needs are changing in the sense that there's less, there are fewer children that are going into hospitals, and more is being done on the outside because the medicines are better and the preventive medicines are better. The pediatricians are better trained. I think Worcester in general is far better medically than it was when I came here, not because of anything I did, but in general because of the medical school. And all the effects of the medical school. It has raised the level. And that's not surprising. I mean, it's just the way it is. So if you introduce if a university puts a medical school in a community, it's going to have a positive effect on the quality of care.
All right, we probably only have about 30 seconds left, so if I ask you one more question, we'll probably run out of time, so I think I'll just...
Okay.